Imagine for a moment you're traveling, maybe enjoying some delicious fresh fruit, or perhaps just drinking a glass of water that looks perfectly clear.
Mm,
Everything seems wonderful, but do you ever stop to think what might be lurking, invisible to the naked eye within those simple pleasures?
yeah,
We want to help you understand this global health concern, its, well, sometimes surprising complexities, and what it really means for public health and your own well-being.
mm. Let's get started.
All right, let's get into it. Okay, let's unpack this. What exactly is amoebiasis, and why should we be paying attention?
Okay, so amoebiasis or amoebabose, it's a cosmopolitan parasitic disease. Cosmopolitan just means it's found pretty much worldwide.
Okay.
It's caused by a protozoan that's a single-celled organism, specifically one called Entamoeba histolytica.
Histolytica. Got
And
it.
it mainly shows up in two clinical forms. There's intestinal amoebiasis and then tisular amoebiasis, which most often affects the liver.
The liver, right. And I remember reading there's a WHO definition that's quite illuminating, isn't
Yeah.
there, from a while back.
Indeed, yeah. Back in 1969, the World Health Organization defined it as, let me get this right, the state where the organism harbors the amoeba Entamoeba histolytica with or without clinical signs.
With or without signs, so you could have it and not even know.
Exactly. That definition really highlights a crucial point. You can be a carrier of this parasite without showing any symptoms, which, as you can imagine, makes detection and control, well, particularly complex.
Okay, here's where, for me anyway, it gets really interesting. This isn't just one single type of bug, is it? It's more like a whole family with some really important differences.
That's a great way to put it, yes. If we zoom out a bit, classification-wise, it's a protozoa. But the really key thing to grasp within that group is, like you said, there are different species. Some are genuinely dangerous, and others, well, not so much.
And these differences are pretty fundamental in terms of how harmful they are.
Absolutely. This is maybe the most essential distinction. The pathogenic species, the one that actually causes the disease, is Entamoeba histolytica.
Okay.
And what really sets it apart, this is fascinating, is its hematophagous nature.
Hematophagus, meaning,
It literally eats red blood cells. Think of it like a tiny microscopic vampire inside you.
what?
Alongside it, you've got other amoebas that are non-pathogenic, or less so, like Entamoeba coli. But the one you really need to know about in this context is Entamoeba dispar.
Entamoeba dispar. That one's the tricky one, right? The look-alike.
That's exactly right. It's a true doppelganger. Entamoeba dispar is morphologically identical to Entamoeba histolytica.
Meaning under a microscope.
Under a microscope, they look the same. You can't tell them apart just by looking. However, and this is the critical part, E. dispar is not hematophagous. It doesn't feed on red blood cells.
So it doesn't cause the disease.
Correct. Doesn't cause disease. This is hugely important for diagnosis, obviously, and for understanding this whole concept of a healthy carrier. Imagine identical twins. One's totally harmless, the other's potentially dangerous. That's the challenge doctors face.
Right, makes sense. So we have this amoeba histolytica or dispar, and it exists in two different forms during its life.
Yes, exactly. Two main morphological forms. First, there's the vegetative form. It's also called the trophozoite.
Trophozoite,
Yeah.
okay.
This is the mobile form. The one that moves around using pseudopods. You can think of them like temporary feet. It feeds and it multiplies.
Right.
Now, for the pathogenic E. histolytica, this form is quite active. It moves rapidly, often in one direction, and its diet includes food debris, bacteria, and this is key to degraded red blood cells.
Yeah.
That's a telltale sign of its pathogenicity.
Because it's eating the blood cells.
Precisely. It multiplies in our colon, and if you look inside it, its cytoplasm, you'd see a clear outer layer and a granular inner part with vacuoles and those characteristic degraded red blood cells.
And the dispar form, is its vegetative form different?
The dispar trophozoite, the non-hematophagous one, is usually a bit smaller. It moves less rapidly, and it just feeds on bacteria and food debris. You find it in the stools, could be diarrheic, could be normal of those healthy carriers we mentioned.
Okay, so that's the active moving form. What's the second form?
The second form is the cystic form, or just the cyst. This is the immobile form. Think of it as the survival pod.
Right, like a seed or a spore.
Kind of, yeah. It's rounded, typically 12 to 15 micrometers, and it's encased in a thick protective shell. This is its resistant form, built for survival outside the body, in the environment, and designed for dissemination for spreading.
So this is how it travels between people.
Exactly. Doesn't feed or multiply in this stage. When it's mature, it contains 4 nuclei. And here's another crucial point. This cystic form looks identical for both E. histolytica and E. dispar.
Ah, so just finding cysts in a stool sample doesn't automatically tell you if it's the dangerous kind.
Precisely. That makes diagnosis tricky just based on the cysts alone. You need to find the trophozoites, especially the ones eating red blood cells, or use other methods.
Fascinating. Okay, so how does someone actually get infected, and how does it decide whether to be harmful or not?
Right. Well, what's really fascinating here is how these tiny organisms navigate our world and our bodies, and yeah, how a seemingly harmless presence can suddenly turn pathogenic.
So how does contamination happen?
Contamination occurs when someone ingests these mature cysts, the tough, resistant ones we just talked about. They survive well in the external environment, and it's all directly linked to what's often starkly called the fecal peril.
The fecal peril sounds pretty grim, but clear.
It is, and it basically refers to any situation where fecal matter can contaminate the environment or food. So the main routes are things like dirty hands.
Standard hygiene stuff.
Yeah, absolutely critical. Also, unwashed raw water or uncooked fruits and vegetables that might have been contaminated.
Okay.
And here's a slightly unsettling detail. Even things like cockroaches and flies can act as vectors. They can physically carry these infective cysts on their legs from contaminated areas to food.
Ugh. Right, okay. Good reminder about covering food and general cleanliness, especially when traveling.
Definitely. So next time you're thinking about grabbing that quick street snack, maybe just give a thought to the fecal peril. Sounds unpleasant, but it's a real reminder of how vital basic hygiene is.
So once these cysts are swallowed, what happens next? You mentioned it can go two ways.
Exactly. Once ingested, the parasite essentially has two possible evolutionary paths or cycles inside the host. The first one is the non-pathogenic cycle.
The healthy carrier route.
Precisely. This is associated with the non-pathogenic Entamoeba histolytic caddis forms in the intestines of healthy carriers. In this cycle, the parasite lives in the gut, multiplies a bit, forms cysts, but doesn't cause any symptoms.
But these carriers are still spreading the cysts.
Yes, exactly. They play a crucial role, unknowingly, in disseminating the disease because they shed these cysts in their stool, which can then contaminate water or food and infect others.
Okay, so that's one path. What's the other one? The one that actually makes you sick?
That's the pathogenic cycle. This is linked specifically to the presence of the hematophagus, the blood-eating E. histolytica, in the intestines of individuals who develop intestinal amoebiasis.
How does that unfold?
Okay, let's walk through it step by step. First, someone ingests the mature E. histolytica cysts. Once they reach the stomach and small intestine, the acidic environment helps break down the cyst wall. This releases a 4-nucleated amoeba.
Okay.
This then quickly divides to form 8 smaller amoebae, called amoebulae. These transform into the vegetative medulla forms E. histolytica medulla in the large intestine. These initially just feed on intestinal contents like waste and bacteria.
And at this point, the person might still be a healthy carrier, even with histolytica.
It seems so initially. The presence of these mobile medulla forms on the intestinal lining might not cause symptoms right away. They can multiply. Some might transform back into cysts to be shed in the stool, continuing the potential spread.
But then something changes. It switches to the aggressive form.
That's the crucial turning point. If the contamination is specifically by the pathogenic E. histolytica cysts, and certain conditions are met, we'll get to those, these medulla forms can transform into the large, aggressive hematophagus form.
The blood eater.
The blood eater. And then it starts trouble. These forms begin to lyse, or break down the intestinal lining. They cause characteristic ulcerations, sometimes described as looking like nail cuts or flask-shaped ulcers. They multiply actively within these lesions.
And that's when the obvious symptoms start showing up.
Exactly. This damage leads to bleeding and mucus production. Some of these aggressive hematophagus forms get swept out in the stools, creating those characteristic bloody mucousy stools. Others penetrate deeper into the intestinal wall, sometimes forming larger abscesses, often described as shirt button abscesses, because of how they look narrow opening, wider base.
Leading to amoebic dysentery.
That's amoebic dysentery, the classic acute intestinal amoebiasis.
Yeah.
But crucially, it doesn't necessarily stop there.
Uh-oh.
These hematophagus vegetative forms can erode into blood vessels in the intestinal wall. And from there, they can travel via the bloodstream to other organs.
Like the liver.
Primarily the liver, yes, but also potentially the lungs, and even though rarely, the brain. This leads to what we call visceral amoebiasis, hepatic, liver, pulmonary lung, or cerebral brain forms. That's a very serious complication.
So what are those conditions you mentioned? What triggers that switch from the relatively harmless minutiform to the dangerous tissue-invading hematophagus form?
That's an excellent question, and it seems to be a combination of factors involving both the host, the person infected, and the parasite itself.
Okay, like what for the host?
Things like an imbalance in the person's gut microbiome, maybe from, say, excessive antibiotic use or poor diet malnutrition. Certain underlying colonic diseases can play a role. And importantly, immunosuppression, a weakened immune system, makes someone more vulnerable.
Makes sense. And parasite factors.
On the parasite side, it comes down to the specific strain of Entamoeba histolytica. Some strains are just inherently more virulent, more aggressive than others. They possess a more potent arsenal of enzymes, things like hyaluronidase, proteases like trypsin and pepsin, that allow them to break down tissues and invade more effectively.
So it's a kind of perfect storm of host vulnerability and parasite capability.
You could definitely see it that way, yes.
Okay, if we connect this to the bigger picture then, you said it's cosmopolitan, but are there areas where it's more common?
Yes, absolutely. While amoebiasis can be found worldwide, the pathogenic Entamoeba histolytica is particularly endemic, meaning it's constantly present in the population in tropical and subtropical regions.
Why there specifically?
It thrives in areas with hot and humid climates, and often where a sanitation infrastructure might be less developed, increasing the risk of fecal-oral transmission. We mentioned a global prevalence of around 10%. That's a huge number of people potentially harboring this parasite.
10% globally. Wow. Okay, let's talk about what happens when things really go wrong. What are the actual clinical pictures, starting with the intestinal form?
Right. For intestinal amoebiasis, the most sort of classic presentation is the acute dysenteric form. Though, interestingly, this dramatic form is only seen in maybe 20% asymptomatic cases.
Only 20%, so what's it like?
The onset is usually quite sudden. It typically involves characteristic abdominal pains. Doctors use specific terms. Aprint, which is that awful, cramping, colicky pain, often accompanied by a false, urgent need to defecate.
Right, like you feel you have to go, but maybe can't.
Exactly. And tenesme, which is a painful spasm of the anal sphincter itself. Really uncomfortable.
And the diarrhea is very specific too, you mentioned.
Absolutely. It's described as dysenteric diarrhea. This means frequent bowel movements, maybe 5, maybe up to 20 times a day. But the stools aren't really fecal because it's mostly a bloody mucus, sometimes graphically called rectal sputum or dysenteric sputum. It is. But here's a really key diagnostic clue. In this acute intestinal form, the person's overall general condition is usually okay, relatively preserved. And, importantly, there is typically no fever.
No fever. That's a crucial distinction, especially from bacterial dysentery, right?
A very important distinction, yes. Bacterial dysentery often comes with high fever.
Okay. And what happens if this acute phase isn't treated properly or at all?
If it's poorly treated or untreated, it can simmer down and transition into a chronic form, sometimes called post-amoebic colitis. This is often characterized by more vague symptoms, maybe alternating periods of diarrhea and constipation, ongoing abdominal pain or discomfort, maybe some loss of appetite. It can grumble on for a long time.
Right. Now, let's move to the extraintestinal forms. When it escapes the gut, you said the liver is the most common target.
By far. Hepatic amoebiasis liver involvement accounts for about 80% of all extraintestinal cases. And what's interesting is that sometimes this liver involvement can be the first sign that something's wrong. The person might not even recall having had any significant intestinal symptoms beforehand.
So it can go straight to the liver, essentially. Or at least seem to.
It can present that way, yes. It often starts as a more diffuse inflammation, called amoebic hepatitis, but it can then progress for a distinct amoebic liver abscess, a collection of pus caused by the amoebas destroying liver tissue.
What are the signs of that? Does that cause fever?
Yes. This is where you typically see significant systemic symptoms. The clinical picture usually involves a painful hepatomegaly. That means an enlarged liver that's tender when you press on the area. And unlike the acute gut form, there's usually a high fever, often spiking up to around 39 degrees Celsius, which is about 102 Fahrenheit. Plus, a general feeling of being unwell, weakness, weight loss, what doctors call an alteration of the general condition.
Okay, so fever is a big flag for the liver involvement. You mentioned other sites too, though less common.
That's right. While much rarer, the amoebas can travel to the lungs and the space around them, causing pleuropulmonary amoebiasis. And even more rarely, they can reach the brain, causing cerebral amoebiasis, which is obviously extremely serious.
Wow. Okay, so this really highlights the importance of diagnosis. What does this all mean for you, the listener? How do doctors actually figure out what's going on inside, and then what can be done about it?
That's the critical part, isn't it?
Yeah.
How do we detect and manage something this intricate? And, just as importantly, how can we prevent it from happening in the first place? Let's start with the detective work, the laboratory diagnosis.
For the intestinal form, I assume stool tests are key. The stool parasitological exam, or EPS, you mentioned.
Exactly. The EPS is the cornerstone for diagnosing intestinal amoebiasis. But it's not just any stool sample. There are some really important conditions for it to be useful.
Like what?
Well, first, it ideally needs to be done before any antiparasitic treatment is started. Or if someone's already on treatment, they usually need to stop for about 3 or 4 days before the test.
Okay.
The sample needs to be collected in a clean, dry, tightly sealed container. And crucially, transport to the lab needs to be fast.
Why the rush?
Because those vegetative forms, the trophozoites, they're really fragile outside the body. They die off quickly. So ideally, the sample should reach the lab in under 30 minutes.
Wow, that's quick. What if that's not possible?
If rapid transport isn't feasible, then the sample needs to be put into a special preservative solution, like 10% formalin or something called NIF solution, to keep the parasite structures intact.
Okay. So once it's in the lab, what are they looking for?
Under the microscope, in a fresh sample from someone with dysentery, they're looking for those live, mobile E. histolytica trophozoites, hopefully showing ingested red blood cells. In less acute or normal stools, they'll look for both trophozoites and the cysts of either E. histolytica or E. dispar.
And they use special stains to see them better.
Yes, various staining techniques are used. Some are quick, temporary stains like Lugol's iodine, just to see the general structures like nuclei. Others are permanent stains like Heidenhain's iron hematoxylin, which give much more detailed views of the nucleus and any inclusions inside the cytoplasm, like those red blood cells.
Is a direct look always enough?
Not always, especially for finding the cysts, which might be present in lower numbers. So a concentration technique is usually mandatory. This basically concentrates any cysts present in a larger volume of stool into a smaller amount, making them easier to find. It can often pick up infections missed on the direct smear.
And what if all that is still negative, but the doctor strongly suspects amoebiasis?
Well, a couple of things. First, culturing the amoeba is possible using special growth media. It's more complex, but can sometimes yield a positive result when microscopy is negative.
Okay.
But also, and this is vital, a single negative stool exam doesn't rule out amoebiasis because parasite shedding can be intermittent. Sometimes they're there, sometimes they're not.
Those coprologically silent phases you mentioned.
Exactly. That's why standard practice is to repeat the stool exam 3 times, usually on alternate days or every 2-3 days, before declaring it truly negative.
Makes sense. Are there more advanced tests?
Yes. For cases where there's strong suspicion of E. histolytica specifically, there are tests like ELISA, which can detect parasite antigen-specific proteins from the amoeba directly in the stool sample. And molecular methods like PCR can detect the parasite's DNA. These can be very specific for E. histolytica.
Okay, that covers the gut. What about diagnosing the visceral forms, like the liver abscess? Stool tests aren't much help there, are they?
Generally not, no. By the time the amoeba has set up shop in the liver, it's often no longer detectable in the stool. And even if you were to drain the liver abscess, which is sometimes done, finding the actual amoebas in the pus can be surprisingly difficult. They tend to hang out in the abscess wall.
So how do you confirm it then?
The key here shifts to serology. That means looking for antibodies in the patient's blood. The body produces antibodies in response to the invasion, and detecting these specific anti-amoeba antibodies is the main way to get biological confirmation of visceral amoebiasis.
What kind of tests are those?
There are several techniques like indirect immunofluorescence, HESAFIC, passive hemagglutination, PHA, or ELISA again, but this time testing blood serum for antibodies, not stool for antigens. Molecular biology, searching for amoebic DNA in the abscess fluid if it's drained, is also another newer option.
Right, so once you've got the diagnosis, what's the arsenal look like? How do we treat amoebiasis?
Okay, treatment. For intestinal amoebiasis, we generally talk about 2 phases or types of drugs. First is the tissue treatment. This uses diffusible amoebicides drugs that get absorbed into the bloodstream and reach the amoebas living in the intestinal wall tissue.
And the main one is metronidazole.
Metronidazole, often known by the brand name Flagyl, is still the reference drug. For adults, it's typically given at a dose of 1.5 to 2 grams per day, divided up for about 7 to 10 days. For kids, the dose is based on weight, usually 30-40 milligrams per kilogram per day.
Are there others?
Yes, there are related drugs like tinidazole, ornidazole, and secnidazole, which often have better bioavailability or simpler dosing schedules. And there are other agents like paramomycin, which is an aminoglycoside, and iodoquinol that are particularly good at targeting the cysts in the gut lumen.
Okay, so that's for the amoebas in the tissue. What was the second part?
The second part is sometimes called local treatment or contact amoebicides. These drugs aren't well absorbed, so they stay mostly within the gut lumen, the inside space of the intestine. They act directly on any amoebas or cysts lingering there. It's often used as a consolidation cure after the tissue treatment to ensure everything is cleared out. Nifuroxicide, Ursfural is a common brand, is an example sometimes used for this, maybe for 6 to 8 days.
And for the extraintestinal forms, like the liver abscess, is the treatment different?
Essentially, the core medication is the same. You need those tissue-acting drugs like metronidazole or tinidazole to kill the amoebas in the liver or lungs. So the attack treatment and consolidation are similar.
Does surgery come into it?
Sometimes. If there's a large collected abscess, especially in the liver, surgical drainage or needle aspiration might be necessary in addition to the medication to remove the pus and help the healing process.
Okay, that covers treatment. But obviously, prevention is better than cure, especially for something this widespread. What are the key prophylactic measures?
Prevention is absolutely fundamental. We can think about it on 2 levels, collective and individual.
What does collective prevention involve?
On a collective or public health level, it really boils down to combating that fecal peril. This means things like robust health education about hygiene and transmission. Crucially, it involves proper sanitation, effective wastewater treatment, and disposal systems.
And identifying carriers.
Yes, screening and treating asymptomatic carriers is really important, especially people who handle food bakers, cooks, food vendors. They can unknowingly spread cysts if they are carriers. Also, simple things like prohibiting the use of untreated human excrement as fertilizer, which still happens in some parts of the world.
Right. And what about on an individual level? What can each of us do, especially when traveling in endemic areas?
On an individual level, the measures are mostly common sense, but highly effective.
That's so.
First and foremost, meticulous hand washing, especially before eating or preparing food and after using the toilet.
The basics.
The absolute basics, but critical.
Yeah.
Then being careful with food and water. Thoroughly washing raw fruits and vegetables, preferably with safe water. If there's any doubt about drinking water safety, boiling it, filtering it, or using chlorination or iodine tablets is essential.
What else?
Trying to control flies and cockroaches in living and cooking areas, as they can be mechanical vectors, and keeping food covered to protect it from contamination. These simple steps significantly reduce your risk.
That's a lot of ground we've covered. We've really journeyed from this invisible amoeba, this tiny single-celled organism.
Yeah, all the way through its complex life cycles, the crucial differences between the harmless and the harmful forms.
To its quite diverse clinical manifestations, both in the gut and elsewhere, like the liver. And we've highlighted the importance of getting an accurate diagnosis and using comprehensive treatment.
Absolutely. We've seen that key distinction between histolytica and dyspar, the 2 potential cycles, disease, or healthy carrier state, and really underlined how vital basic hygiene and public health measures are in controlling its spread.
So as we wrap up, what will you remember from this deep dive into the hidden world of amoebas? Maybe it's just the sheer complexity packed into something so incredibly small.
Or perhaps it's that stark reminder of how closely our personal health is linked to our environment, sanitation, and our collective practices as a society.
What action, if any, might you take armed with this new knowledge? Maybe just being a little more diligent with hand washing or more cautious about water sources when you travel.
We hope this deep dive has illuminated this important and often overlooked global health issue, and maybe sparked a bit of curiosity for you to continue your own exploration.